This conference will now be recorded.
Oh, thank you. So RD, Jake, Peter, Dennis. You got another caller there, Jake.
Yeah. Somebody just joined us on the telephone?
Yeah, that might be me. This is Roy Patrick, coming in on a different phone.
Roy, did you say?
Yes.
Welcome to the call, sir.
Thanks.
Oh, I remember your name. Oh, it's Roy. Roy.
Yeah. Yeah.
Yes. I thought you said Rory. We once had a Rory, but it's Roy. Hey, Roy.
Okay. Hi.
Yeah. And I thought it was a Rory. I remember once having a guy, Rory, on the telephone. Sylvester. We got feedback from somebody. Okay. And Paul Frieda. Okay. So we'll get cracking.
Hey, don't forget Eric.
And Eric.
And George.
I got you, George.
Oh.
Your number, man.
You still the good-looking guy?
We're getting a lot of echo from either Peter or George. Peter, Paul Frieda or George. I'm not sure which.
I'm on an iPad.
I'm on
It's you, George. Just turn your volume down a tad. It should kill it.
Okay.
So do we have?
It's Paul. It's showing up as Paul.
It's showing up as Paul. Paul, you may need to turn your volume down a little bit too.
Turn my volume down, okay.
Yeah.
And better?
Well, we'll see. Yes.
How's that for me?
Yes. Ken Anderson. And we have two Roys on there, Jake.
Uh-oh.
Or just have folks mute until they want to talk.
There's a concept.
Yeah, I wrote down Roy as caller number 4. I don't know who Roy Sabrick was. That you that just joined us?
Yes.
Oh, yeah. Roy, are you on the telephone? Roy
Jake,
Sabrick?
it's me that put it. Jake, it's me that put the last name in.
Uh-huh. You're fired, Peter. How do we figure out who's who? I'm not sure.
Well, here's what I'm going to do. I'm going to tell you who I see on the call, and then we'll figure out who we haven't called, and then whatever it is, we'll find out.
Okay.
So
Good thought.
I see Jake, Peter Kafka, Dennis Correa, Eric Bookbinder, Len Sierra, Dr. George, Roy Saverick, Schreff, Sylvester, Paul Frieda, Ken Anderson. Have I missed anybody?
Alan.
Who was that?
Alan.
Alan. And have you been on the call before, Alan?
Oh, first time.
Oh, okay. Well, welcome. Welcome.
Thank you.
Welcome. So we'll get. I think we've got everybody. I think we're squared away now. So
We still have two Roys. Roy has left.
Not
Okay.
anymore. Not anymore.
Problem solved.
Okay. Who's going to sort you guys out in the next 4 weeks when I'm not here? Len? Len, you're in charge. When I'm not here, you've got to keep these guys squared away. Stop them messing around like this, okay?
Well, try, but I don't have all the powers you have. You know, I can't even tell who's talking, who's not talking.
Okay. Alan,
Yes.
welcome to the group. We usually accord people that have never been with us before the floor to begin with to find out a little bit about you and then to try and help you with any issues you have. So if you're comfortable doing that, we'd like to give you 20 minutes or so to talk about your situation.
Sure, sure. I'm newly diagnosed with prostate cancer,
Right?
and I had a biopsy.
Hang on one second. I'm Paul Frieda. I'm going to mute you. We're still getting a lot of echo from you. Rick will call on you when it comes your turn, okay? And we'll unmute you. Sorry.
Okay.
Just
Were you talking to me? Were you talking to Alan?
No, we weren't.
Paul Frieda. We're getting echoes from one of the other callers.
Right, Jake, just do it. You don't have to advise them. Just mute them if there's an issue, because otherwise we interrupt. So you're newly diagnosed, Alan. And what was your diagnosis?
I had a biopsy, and it came out with a Gleason 4+5 on the right mid-lateral, and a Gleason 3+4 on the left lower lateral. Prior to that, I had rising PSA. It was increasing relatively fast over the last year. It went from I got a chart 4.9, 5.4, 5.7, and then I had the 4K score done. That came in at much higher, 7.8. And then in June, I underwent a 12-core random biopsy. I initially requested an MRI, but the insurance company denied it, saying that you first have to do the biopsy before they would do the MRI. So I did the 12-core random biopsy, got the results back about 2 weeks later from Quest, and they said it was initially 3+3 on the left side and 4+4 on the right side. I had these slides sent to Johns Hopkins in Baltimore for Jonathan Epstein. And they came back with an upgrade of 3+4 on the left side, 4+5 on the right side, Gleason 9.
Okay.
And subsequent to the initially the urologist had did a DRE on me. He said that he couldn't feel any nodules, but about a week before the biopsy, I had a proctology exam, and the proctologist felt a nodule on the left side. Subsequent, I had another DRE from the radiation oncologist. He also felt the nodule on the left side. So there's a possibility it's the left 3+4 tumor that may be pushing out, causing that stage. So they diagnosed me as T2, stage T2A.
Okay.
What I'm consulting with various facilities. I happen to be in New Jersey to try to figure out where to go for treatment. I've seen 3 radiation oncologists to date, and they all have a different opinion. First one said we should do IMRT for 9 weeks, concurrent with android therapy for 2 years. And then if the cancer reoccurs, then we can do brachy. He didn't mention whether it was high dose or low dose, and at that time I wasn't aware of the all the terms. So he basically said brachy. The second doctor I saw, she recommended 2 months of hormone therapy before, and then CyberKnife, 5 sessions, followed by additional hormone therapy for 6 months to a year. And then the third oncologist said hormone therapy plus external beam radiation plus high dose brachytherapy plus 2 years of hormone therapy.
And where was that third one?
The Third one was Sloan Kettering, and it's the satellite of the Manhattan office in Middletown, New Jersey.
Yeah, I would have guessed of the three of them. I would guess that the third one. I would have guessed the third one was Sloan Kettering. So I got a couple of questions for you. How many cores were positive out of the 12?
The only two cores. One core was the Gleason 4+9, and the other core was the Gleason 3+4, and that was only 20%. And the Johns Hopkins came back. The upgrade, the Gleason 4, was only 5% of that 20%.
Okay, so there isn't
the 4+9. They didn't give any percentage because they said they don't give percentage once they hit the 5.
So it sounds like you don't have a lot of cancer, but what you have is pretty aggressive. Is that true?
Yeah, that's they're saying because of Gleason 9, high probability that saying it may have spread to the lymph nodes or bone. I did a bone scan 2 weeks after the biopsy and the CAT scan, and they both came negative.
Right.
But all of the doctors saying, that doesn't necessarily mean it has it microscopically spared already.
Yeah. And how old are you, Alan?
I'm 62.
So I'll give you my 2 cents, and then maybe Peter Kafka will talk to you, and then we'll throw it open.
Now, the one thing I haven't done is an MRI yet, because I think I probably have to do that at some point. There's another problem. They're telling me, at least the second doctor called my insurance, told me they would only approve it once. And as part of radiation therapy, they need to do an MRI to map the the targeted radiation. So if we do it now, they're not going to pay for it when they do the marking.
Even if it's for different purposes? Even if one is for
I don't know. I was kind of surprised. The second doctor had her insurance person contact Aetna, and they said that you can only bill the MRI one time only.
I'm surprised, and I think if you went in and spoke to the Sloan Kettering folks, that they may be able to get it through. But let me just back up a little bit. It would be helpful to know the extent of the disease, and probably a high Tesla MRI would tell you that.
Right. The 3 Tesla MRI.
Right. But the issue, the question really is, would it change your treatment decision? And I would suggest that it probably would not, because with a diagnosis like yours, if you're going to do radiation, the field isn't going to change. Even if they see the lymph nodes, they're going to radiate the whole pelvic girdle either way. So if they saw the lymph nodes, they'd be radiating the pelvic girdle, and even if they didn't see the lymph nodes, they'd still be radiating the pelvic girdle. And the same with the seminal vesicles, and the same with the area around the prostate. So, I don't really think there's going to be a huge change in treatment protocol. And I always, when we're navigating people, the question we ask them is, if you do this test, how will it change your treatment? And I'm not certain that while it would be very helpful to have done an MRI beforehand so they knew where they were biopsying, they're probably going to blast the whole of the prostate anyway. It's not like they're picking out spots in the prostate. Now, the brachytherapy, it might be important, because when they place those rods, they want to know exactly where the lesions are. So you might have to do some sort of additional scanning if you were selected brachytherapy. I would say on that score that when you don't have a lot of density, as you do not, then you might be a candidate also for low dose brachytherapy instead of the rods, instead of the high.
Are you talking about the seeds,
Yeah.
the seeds, that lifetime implantation, the seeds?
Yeah. So I can tell you from my situation, I had 7 out of 14, I think 7 out of 14 positive cores, of which I think 3 were 4+4, and they did seeds. They didn't do rods because I didn't have a lot of bulk. You know, I had enough cancer in there, but it wasn't solid. Whereas I had good buddies, still good buddies, who had like 11 out of 12, and they did high dose because there was a lot more cancer actually in the gland. So a couple of other things I just want to say quickly. One is that my personal decision was to do radiation and hormone therapy because I did not think that the surgery alone would capture my disease. And so I would endorse what you're doing. The likelihood, if they suspect metastatic micrometastasis, is that you're going to have to do radiation anyway, and you're going to have to do hormone therapy anyway. So why put yourself through a whole extra set of protocols in terms of surgery? And I ran, you probably have done this too, I suspect. I ran the Memorial Sloan Kettering nomogram.
I did.
And in my own case, there was a 70% likelihood that I'd need more treatment beyond surgery.
Yeah, so, in my when I ran my nomograph, I think there was a 76% probability of extracapsular extension.
Right. So, you know, when you're faced with those sort of odds, to me, it doesn't make a lot of sense to roll the dice. But I know people that have done, and you know, you get lucky, you get lucky. But I didn't want to put myself through surgery if I didn't need it. You've obviously had some good coaching already. How did you find us, and what support groups have you been to?
I actually called a cancer navigator at a local hospital in the Central State because I went there for I went there for the CAT scan and the bone scan. So I just walked to the nearest office and asked around. They led me to a cancer center there, and you know, they had a cancer navigator. And I contacted her. She gave me a lot of you know, brochures. One of them is the Us Too brochure.
Okay.
The Us Too. Let's see. Get Connected. So that's how I found your website today, and I'm glad I did because I also posted a question on the Insight. I haven't got a response yet, but it's very good. A patient perspective rather than listening to doctors who may or may not be biased.
Well, you probably will get. I used to be very active on there. I just don't have the time. But some of the guys who are on this call right now do respond. But you can ask us. You can ask us any questions. So let me go to Peter and check back in with you and see what questions you have, and then we'll open it up to the guys. Peter, what would you like to say to Alan?
Yeah, Ray, I think we should probably. I think Len has so many similarities because Len was treated at MSK with radiation. You know, my experience with primary treatment, you know, was quite a bit different. So I think Len probably could give him some insight first.
Okay. I agree with most of what Rick said, that you should have radiation to the full pelvic girdle. There was a recent study just published showing that the high dose HDR brachytherapy plus IMRT had a superior 5-year progression-free survival than any other type of radiation.
Right. I did research that. There's a UCLA Krishan study and an SN Canada study that, not only that, but they mentioned the hormone therapy, the combination of the three, hormone therapy, external radiation, and HDR had a much better outcome.
Yes.
I asked one of the radiation oncologists. The response is, well, you can get a study to conclude whatever you want. So he wasn't really convinced that was the way.
Right.
And he
Now, that was actually recommended to me by one of the radiation oncologists at Sloan Kettering, that I have the high dose rate brachy plus IMRT. However, I didn't go with the HDR brachy primarily because I spoke to Chris King at UCLA, who is also a radiation oncologist. He advised me not to do that because of higher risk of urinary toxicity.
Right.
So I didn't go with that, but it's no doubt from the recent study published that the results are better with HDR.
Okay. The doctor at the satellite Sloan Kettering, New Jersey, Dr. Khan, he basically said yes, it has a much higher toxicity. Talking about possibly grade 3, but on the flip side, it seems to have a higher cure rate.
Right.
I think.
By the way, Rick, I don't know if you're aware, you're sharing your desktop with everybody.
Oh, am I?
Taking up a lot of real estate.
Oh, well, okay.
Yeah. Alan, do they do the high dose brachy at the satellite MSK, or do you have to go into the city?
No, I have to go to Manhattan for that. That's the other downside.
That's what I figured. There aren't a lot of places that do that. And as a result, there's a lot of doctors that discourage people from doing it, thinking that it's gone out of favor. But as Len said, it's actually a very effective treatment. I mean, I've got another guy I've been counseling that was discouraged from doing it, but I suggested he look into it.
Fox Chase in Philadelphia, in 2015, they basically stopped doing the seeds in favor of the high dose because of much better outcomes from their patients.
Mm-hmm.
So they're basically giving a thumbs up for high dose over the seeds. And my understanding that Robert Wood Johnson in New Jersey may have it, but haven't. My consultation is in 2 days, so I'll find out more about that. They claim they do therapy, high dose.
Keep in mind when you interview, when you get other opinions, it's not just the machine. The machine's a very elaborate machine, but you want to have a radiation oncologist who's really done a lot of this work and knows the ins and outs of it, because it's pretty specific. So ask them how much HD they've done, or what their experience is, and so forth. You want to go with crackerjack people.
Well, it's tough to find out because I asked around. I asked my primary doctor. He couldn't give me any guidance, and he basically did indicate that he had 2 patients that went to Sloan Kettering. They were not happy, and I just called today and asked him if he can give me more details. I was told that he's not allowed to release the details about his patient, confidential. So there's really no help, because I was trying to find out whether he was talking about prostate cancer and which Sloan Kettering they went to, the one in Manhattan or the satellite in Middletown. And the response I got from his nurse is that he can't disclose this information because of patient confidentiality.
If you want to speak to someone who's done HDR, I have a buddy who did it on the West Coast at UCLA, and he'd be glad to talk to you about the procedure. The experience.
Len, can I ask you, who did you see in Sloan Kettering, Manhattan for the brachytherapy?
Well, first let me say it was Oh boy, I'm sorry.
Is it Zaleski, the head of the?
No, there was a woman. I can't remember her German-sounding last name. She was the one who recommended that I have HDR plus IMRT, but I actually had just the IMRT done by Boris. Wow, I'm
Muller.
brain tonight. You know who I'm talking about, Rick. Boris. What's his
Muller.
last?
Boris
Muller.
Muller.
Boris Muller, who is in the Westchester MSK office.
Okay. So you had your treatment in New York, basically.
Westchester, New York. Yeah, not
West.
the downtown, not the 68th Street facility.
Okay, got it.
Just because it was convenient for me. I live in Connecticut.
I see. Have any of you had any experience with the so-called proton therapy, IMRT? I was told, reading the literature, that it has a much lower incidence of side effects. I read a research paper, and it said that the improvement was about 1 to 2% in the three categories, incontinence, sexual dysfunction, and rectal problems. Does anybody have experience with that? Is it worthwhile to get that? Because Robert Wood Johnson does have a proton therapy machine in New Brunswick, and there's also another one in Somerset, New Jersey, that has the proton therapy. So I'm wondering if I can do the pelvic radiation with the proton therapy to try to minimize, the exposure I'm going to get from radiation, and then do the high dose brachytherapy along with the.
So, Alan, what the first thing we'll talk to you about it, but the first thing I suggest you do is, if you go to our website, you go to recordings and decks, and listen to the recording from July the 10th. I think it's about halfway through, but when you click on it, you'll have the opportunity to put in proton beam, and there's a search, and it'll take you to the first place, I guess, proton beam is mentioned. And then it'll
July 10th, 2018.
July 10th, yeah, and there's a keyword search. Now, one of the guys who attends the call regularly, he's not on it today, he's at an air show in Wisconsin. And one of the guys who attends the call regularly is very, very knowledgeable, and he gave us a pretty good lecture, which resulted from his research that included seeing and speaking with Dr. Rossi in California, who Peter can also talk to you about. The bottom line is, yes, you're probably right. It is overall a little less invasive. There is a research paper that suggests that proton beam has lower side effects to the rectum and the anus, whereas it has higher side effects to the gastrointestinal area. That's
really?
That's what this study, and I can send you that study later. But that study was done a few years ago. But I strongly suggest that you listen to this discussion that Jim McCoy, this little sort of pocket lecture that he gave us a couple of weeks back, because it was really good and very, very helpful.
So when you say the website, are you talking the Us2 website?
No, the ANCAN website, our website.
Okay, let me see.
Our website is ancan.org.
Okay, ancan.org, right. I'm on it right now, I see. Okay.
So if you go to, under resources, if you go to recordings and decks and click that, there's the most recent recordings are at the bottom, and you want to listen to the one on July 10th later on and search for PBRT or proton beam or something like that, and you'll be able to listen to Jim and you'll be a lot more educated. Peter, did you want to say anything about proton beam?
Yes, well, I'm actually I've already made arrangements. I'm gonna go through it in November for myself, but I've already done my primary treatment with surgery and IMRT, so I'm doing it for recurrence. But you might want to, Alan, if you're getting pushback from your insurance company about multiparametric MRIs, you might want to check with your insurance company whether they will cover proton therapy, because it's
what I did, I found out
controversial.
that the Somerset facility is out of network. If I switch my insurance to a PPO, the out of pocket is $3,000, because that facility basically has a deal. If you pay out of pocket, they would charge you $10,000, and if I go to the PPO, the PPO will cover the out of pocket maximum is $3,000. So the worst I can get hit is $3,000 for that. The one at Robert Wood Johnson turns out to be in network. I'm not sure if that makes it better because they are in network.
Okay. Again, it's the machine is one thing, but the radiation oncologist is another whole animal, and you really want to make sure you've got somebody who's really on top of this. Ask them how much prostate work they do, because a lot of proton centers focus on pediatric care and eye issues and so forth, and they might not do a lot of prostate work, and it's very delicate work.
Right, because the three oncologists I spoke to, they don't primarily do prostate. It's all like a minority of their cases, which is unfortunate.
Yeah,
I'm not sure. I haven't spoken to him yet. But looking at the statistics,
you want to hunt around for a really good person.
Yeah. So is there anyone else? We need to move on shortly. So is there anyone else on the call who would like to talk to Alan before we move along?
Rick, I'd just like to let Alan know that I personally have never heard of anyone getting proton therapy for the wide angle of the whole pelvic girdle radiation. I don't know if anyone else on the call has ever heard of this. They usually use proton beam for cancer that's contained within the prostate.
I see.
Well,
makes sense.
You know differently, Rick?
Roy Saverick, do you want to say anything about proton beam?
Sure. So I'm going in tomorrow for my first treatment of 28. So I probably would know a bit more of the mechanics. But from what I understand, it's if you use the pencil beam machine, which not all of the centers have, they can do different strengths on the prostate and different strengths on the surrounding pelvic area based on what the MRI has shown and so on. So I actually changed the center I was going to one that had the pencil beam machine, which is a bit newer, to have that flexibility because I wanted to do the surrounding area as well as the spot that has the the infection in the prostate. And in looking at it, we kind of decided about what strength to do for the different areas and how wide an area to do and so on. And to me, that was very important.
Okay, great. That'll be good information.
And anyone else want to say anything to Alan before we close up?
I have one final question about the hormone therapy. Now, should I seek out a medical oncologist, because they've talked about hormone therapy, but they didn't specify which of the various injections or oral medications they would be using, and I believe there's a difference of opinion depending on which doctor you see on what type of hormone therapy, how long, and what is continuous or intermittent.
Well, the continuous intermittent is not applicable for you. So that's something we talk about often on here. You'll find it a lot in previous calls, but it isn't an issue for you. When you're doing what's called adjuvant hormone radiation, which means it's being added to the adjuvant hormone therapy, meaning it's being added to the radiation, you do it continuously for a set period of time. The issue that you're going to be faced with is how long. And the traditional wisdom has always been that if you have a Gleason 8 or higher, you do it for 2 years or more.
Okay.
I did mine for 28 months. Some of the doctors more recently, because of the studies that have come out, suggest 18 months. There are a few doctors that suggest 12 months. I don't think any good doctor would suggest less than 12 months, and it would give me concern that one of your radiation oncologists suggested to you 6 months with a Gleason 9. So I would be looking for a second opinion on that. 2 of the 3 said 2 years. 2 years is tough. All the guys on this call have experienced hormone therapy for some period of time, some of them for a very long period of time. And the longer you're on it, the tougher it gets. But if you can stick it out for at least 18 months, it's going to give you the best chance of beating the disease. I know guys that couldn't stick it out and had bad disease like yours to begin with, and the disease came back. Is that because they didn't do long enough on the hormone therapy? I don't know. But the guys that I know that did longer, including myself, have gotten a durable remission.
I have added problem is I'm diabetic. I've been diabetic for about 24 years.
Oh yeah, well that does because of the metabolic syndrome. So, I don't think I would go anywhere but Memorial Sloan Kettering with those sorts of issues, because Memorial Sloan Kettering is going to have the oncologists, and the answer is that I probably would get an oncologist on board if I was diabetic, because it does complicate matters, and we can refer you to some people there. A lot of times we just referred somebody to an oncologist from Memorial Sloan Kettering, and they wanted to defer to their radiation oncologist. But I think that probably it's not a bad idea to get a genitourinary medical oncologist on your team early on. I don't know. Is there anybody on the call who's diabetic and on hormone therapy?
Well, it's Larry Fish. I became diabetic as a result of the hormone therapy, I guess.
Yeah.
I was kind of pre-diabetic before, because of the weight gain.
Yeah, and that happens. I can tell you, Alan, that we don't have time to get into it, but God willing, you'll be back on the call. But I can tell you that exercise is going to be incredibly important.
Right.
Incredibly important.
If I may, final question. My biopsy was middle of June. With a Gleason 9 score, how much time do I have before I should make a decision? Keeping in mind that the Gleason 9 may spread during this interval. Generally,
well, I can only tell you my situation, and I think every doctor would give you different advice. But I was diagnosed, as I told you, with a Gleason 8, and I was diagnosed in August, and late August, and my doctor told me I had to make a decision before the end of the year. So he was basically giving me 3 to 4 months to make a decision.
3 to 4 months. Okay.
Yeah,
because I asked the second doctor, and she said, I need to make a decision in 4 weeks.
Your
And
PSA,
the others didn't give me an opinion. The other two didn't give me an opinion.
your PSA has gone from 4.9 to 7.8 over 12 months. And when was your last PSA done?
That was done in May, and actually the 4.9 was December of last year. No, I'm sorry. Let's see. Look at the chart. It was the 4.9 was August of 17, and then the 5.4 was in.
Okay, I have to move you along. So August
Okay.
17 to
Yeah, the 4.9 was August 2017. The 5.4 was December 17, so it jumped. And then April of 2018 was 5.7.
I got you. August 17 to May 18, and I assume you're going to get another one. Look, we can't give you medical advice. I can only tell you what my situation was, and I can also tell you that if I had your issues, I'd be focusing on Memorial Sloan Kettering, largely because if there are any complications, they've got the best cadre of doctors to support you. So you're going to stay in that system.
Is the medical oncologist? They told me they have a team, but they didn't mention that. So if I go with Sloan Kettering, they're going to give me their medical oncologist, or should I get somebody on my own?
No, if you go to Sloan Kettering, we'll tell you. We'll give you some names, but the names we're going to give you are all in Manhattan.
Manhattan. Okay.
Yeah. So
they were telling me I can get the therapy treatment here, the 5 to 9 weeks, and then go to Manhattan for the brachy.
Right, but what I'm saying to you is that the GU Medonc is going to be based in Manhattan. That doesn't mean to say that you've got to go in and see them every time you get a shot, but that's where they're based.
Right.
Okay?
Right.
They don't have any, as far as we know, they don't really have any good GU medical oncologists out in Jersey. At least, we've looked before, and not in Baskin Robbins or Monmouth, so I don't know about Middletown. So, and we'd say go make sure that all of the medoncs out there are generalists. But let's do this. I hope you'll keep coming back to this call. We'll continue to help you. We'll talk to you about hormone therapy. We'll give you lots and lots of information on hormone therapy and support you through that. If you would like to be added to our distribution, so we let you know before each call, we can do that.
Sure, I would like.
You can give me your email right now, or you can email it to me. I can give you my email if you prefer.
I can tell it to you right now. It's Z as in zebra, X as in X-ray, Travis, Travis, the number 2, at gmail.com. So it's zxtravis2 at gmail.com.
Okay, and is Travis your last name?
Yeah, my first name is Alan.
Yeah, Alan Travis, got it. All right, Alan, and what part of Jersey are you living in?
I'm in Central Jersey. That's why I'm looking for,
Whereabouts?
I'd rather not travel to Manhattan if I don't have to, but,
Right. Like, are you in Parsippany or somewhere like that?
No, I'm in the actual central, like the Monmouth County area.
Okay.
Ocean County. I'm actually in Ocean County, so I'm on the border between Howell and Lakewood.
Okay. I know Lakewood. Okay. So we'll add you to the list. Keep coming back. Keep asking us questions. And if you need to get hold of us, you can send an email to me, rd@ancan.org, if you want to be connected to any of the guys or anybody that's done this before, and we'll work with you.
Okay. When you say RD, small R as in Robert, D as in David,
Yeah.
small cap.
Yeah.
RD at
ANCAN. ANCAN.
Okay. .org. Okay.
Yeah.
Got it.
Okay.
Thank you all.
Pleasure. So hang in. We're going to be talking to some guys. I just want to give you a heads up. We're going to be talking to some guys with pretty serious disease, and I don't want you to feel, discouraged. So I just want to give you, a heads up warning about that ahead of time. Okay.
Great. Thank you all again.
Let me just see who else has joined us since we did the original roll call, and I think I've got Larry Fish. All right, so I'm just going to run through. I don't know if Shreff's back on or off because he was having trouble, he said, with his connectivity. So I'm just going to run. I'm going to run down the list and see who'd like some time, and hopefully we'll get everybody. And if I miss anybody, forgive me. We'll come back to you. So, Jake, anything you'd like to talk about tonight?
No, Rick, not for me tonight.
Okay. Peter, anything you'd like to talk about?
No, not particularly. But I mean, if there's a minute, I could mention something, but nothing particular.
Well, okay, so we'll put you in. That's okay. Dennis, anything for you? Or you're about to leave us, aren't you?
Yeah, I'm good, Rick. Tomorrow is my routine blood work scheduled, and hopefully everything will continue to be okay.
I hope so too. And the new Sean, Mr. Bookbinder. I see you've lost your locks there. Is this true? Can we hear you? We can see you, but we can't hear you. No sound. No sound. Okay, we'll come back to you. Keep working on that sound. We'll come back to you. Len, anything for you?
Nope, like Dennis, I have my 3-month blood work tomorrow. So next call, I'll have something.
No, I hope they don't get all this blood work mixed up. There's going to be a lot of blood work tomorrow. George, how about you?
Maybe just a couple of minutes.
Okay.
Can you hear me now?
Roy, would you like to tell us a little more about how you made your decision and where you're going and all?
Yeah, I'll do this quickly.
Okay, hold on.
Support call.
Okay.
I'm just getting a sense. Shreff, are you with us right now, or you're not with us? Do we have Shreff? No, we don't. We'll watch out for it. Paul Frieda, I've got to get rid of that echo, so I've got to ask you next. Anything for you today?
I'm okay tonight, thanks.
Okay, we're gonna mute. I'm sorry, but we're gonna have to mute you again because we're getting the echo. Okay. Sylvester, anything for you tonight?
No, thank you very much.
Okay. Ken Anderson, anything for you?
No, Rick, I'm good, thank you.
Okay. Larry Fish, anything for you?
Okay.
I'm good tonight, thanks,
I'd say I would help, but I just can't, But it's just everything. I come up with these things and I can't do anything.
Hold on a second.
I mean, I can't even go.
Eric, hold on. Let's mute Eric. Oh, we did. Sorry, Larry. Come back.
No problem. I'm good this week, thank you.
Okay.
I'm sorry, it said I was muted.
Well, you are. You can be unmuted now because I am assuming you're going to give us a bit of an update. We've been wondering about you.
You want me to do it now?
No, I'm going to come back to you.
Yeah, absolutely. Okay.
but very soon. Okay. And Rich Jackson, anything for you tonight?
Just a quiet night at home,
Okay.
taking notes. Thank you.
I have something for you, so don't hang up at the end. I've got to ask you a quick question to help me with my setup on my new
Okay.
machine here. It's just a clarification thing, a little education I need. All right, so did I miss anybody? Did I check in with it? Did I catch everybody and check in with everybody? Okay. We should have time to get through everyone. We've got plenty of time here. So, Peter, why don't you start off with your little question?
Okay, just kind of reporting in here. This is an odd one that I just experienced this last week. My CVS specialty pharmacy screwed up this month and never sent me my Zytiga. So I actually ran out of the prescription. I got on their case yesterday, and I think it's coming. It should be in my mailbox today. But I was on the phone on the weekend with them in Pittsburgh, and they couldn't give me an answer why they messed up. They had record of me calling and putting the order in and everything, but they never sent the stuff. I don't know if anybody's ever had experience with that, but they can have you on a string. So fortunately for me, my oncologist gave me some sample Zytiga, which I have stashed away, so that I didn't miss like 3 days of it. But it was just a very odd experience, kind of being at the mercy of a specialty pharmacy. It's not the place, you can't just drive to it. They send it to by mail. That's one experience I had. The other out is, as I mentioned, I am going to do proton radiation at California Proton with Dr. Rossi. And I worked out the logistics yesterday. Any of us that have had to have radiation or any kind of therapy at a distance from our home and had to find lodging and all that stuff, it's a real bugaboo. But I think I've got it figured out. Because your insurance company doesn't compensate for it. But I do have a friend who's usually on our low and intermediate calls, and he went to Arizona for some kind of alternative treatment, and he got the American Cancer Society to give him his round trip plane fare and lodging for almost a month because of his financial situation. So just reporting in on different things that I've noticed, that there are provisions around to get the treatment you need, without thinking that there's unsurmountable obstacles.
Yeah.
So that's all I have.
Thanks. I do know, I know that ANCAN does have, that American Cancer Society does have pretty good programs, and there are a couple of other people that that provide lodging programs. I think I've got a list of them somewhere. If anyone's interested, they can contact me. If anyone does have issues about not getting their drugs, let me know as soon as you can. If possible, we can help you. I can't promise that, but we may be able to find some solutions for you if you think you're going to be out of drugs. Peter, I'm glad you made a decision. You want to tell us why you decided on Rossi rather than other alternatives? I mean, this is for some spot radiation, correct?
Well, it's more than spot. It's essentially going to be 20 days of proton therapy targeting abdominal lymph nodes. So it's all north of my previous IMRT radiation, and I think Rossi's had a lot of experience. He's treated about 9,000 guys with prostate cancer, so I feel confident. And I think I wanted to go with proton because I feel there's might be less collateral damage because we're dealing with the abdominal area now, not the prostate bed. Almost all our organs, significant organs, are up in there. So I feel at ease with the thing. I've talked it over with a number of people. I've talked it over with some people that have had this experience and had it successfully. So that's my game plans for the month of November. I'll be in San Diego.
And what do you make of that research that says that PBRT creates more damage to the abdominal area and less damage to the rectum and vice versa? Has Rossi commented on that, or do you have any thoughts on that?
No, but I'll talk to him. But I think that's probably mostly for primary treatment, dealing with urinary versus and intestinal stuff down below the belt.
Okay.
My concern is stuff above the belt.
Okay. Fair enough. Okay. Anybody else want to ask any questions of Peter?
Peter, you said 20 days of proton therapy. So they're not just doing spot radiation, right?
No, they're going to target the lymphatic system there.
Okay.
Because, I mean, the thought is that, my disease is systemic now, and it's shown up in 2 lymph nodes, but the odds of it being in other lymph nodes on a microscopic or lower level, it wasn't able to be picked up by the scan, pretty good. So my hope is that I can get a year, 2 years out of this, go off of hormone treatment after the radiation, and that's practical and see. But right now I'm tolerating the hormone treatment really well. I mean, I feel so great. I asked my oncologist if I could get a testosterone test with my last blood test because I felt like I had testosterone still because I go to the gym willingly. I feel strong. I feel energetic. So he said, sure, but I don't think you have any. And so he gave me an order for testosterone, and it came back at less than 3.
Wow.
So he was right, but as Rick said earlier, I think exercise really makes a difference. Regular exercise regimen, and getting out there 5-6 days and really hitting it makes a big difference.
So Peter, are you considering paddling that outrigger back to the mainland?
Yeah, I wish.
All right. All right. Well, I mean, that's all good news. And let's go, just because we're in the same vicinity and it's a good segue. Let's go to Roy. And Roy, tell us sounds like you're not going to see Dr. Rossi now, but you are going to do proton beam. Is that right?
Yeah, I am doing the proton beam with the pencil beam with Dr. Rossi, the same place that Peter is going to, and that starts tomorrow. But I just had one question because I don't want to use up a lot of everyone's time. I was out to see a new oncologist in LA last week, and he recommended that I start taking Zytiga, in addition to Luprin. That's what I said that. Okay. And the only question I have is what would be the percentage of gain in taking both hormones while I'm doing the radiation, in light of the fact that the Lupron is working so well, and my testosterone is also less than 3, my PSA is 0.1,
Right.
And the Zytiga also is a testosterone inhibitor. So what would be the advantage of taking the Zytiga since my blood work comes back so low that there is no reason or need for testosterone reduction or PSA reduction?
Okay, so let me turn the question back on you, Roy. How did Dr. Turner explain that?
Dr. Turner said we want to be as aggressive as we can, and they work slightly differently, and this is why I want you to be more aggressive than just the basic treatment of Lupron and radiation. We could add this, and at the beginning of the stages, the goal is to try to kill this thing and not just control it.
Right.
So let's be more aggressive, and that was his suggestion.
Right. So, and is he comfortable that he can get your insurance company to cover it?
Not yet. I spoke to him yesterday, and they're trying. They have a pharmacy that deals specifically with that, and I have to do it through them. And I gave them the place to mail it to once he gets approval, if he gets approval, and then I'll know. And that's combined with the progesterone, and as far as controlling. But hopefully, this is the right way to go, because it's a trade-off always of being as aggressive as you can with the side effects that come with it.
Right.
Enhanced pressure, in your blood, attacking your bones, attacking the phosphorus in your body, and all these things that the Zytiga is capable of doing. But he wants to monitor it every month, and he gave me a 1 year, month at a time prescription for the blood work.
Okay,
so we can monitor it for the negativity.
Right.
But I'm concerned about the trade-off of the side
right.
effects. I'm not sure how much I'm gaining, and it's really hard for me to measure that.
Right. So a couple of things. Do we know the extent of your disease yet?
3 folks in a row, from Dr. Rossi to Dr. Turner to the urologist, all said my sample shows number 9. Just accept it's number 9. It's 30% of number 9. Epstein said it's a number 9. There's no reason to do an additional biopsy. There were 6 samples they looked at, and they feel that I have to kind of live with that and go forward from there. So everyone's being aggressive because of my Gleason 9.
Right. So but we have really no idea how much cancer you have in your gland. We just know that this sample was picked up during the TERP, but we don't really know whether you've got a lot of cancer, a little bit of cancer, and where that cancer is. Is that right?
That's exactly right. I did an MRI with in the Proton Center, and the report came back. It was a little too general for me, and it said, this little lesion looks suspicious. I got reports like that. So I wish they said, boy, definitively one way or the other, but the MRI didn't show really, wasn't illuminating at all.
So I guess here's my thoughts, and then I'll let the guys talk about this, because it is really a challenge. The first thing is, I really would want to know, if I was considering taking Zytiga, I would really want to know where that 4+5 lesion was, because if it was right on the edge and there was a lot of it, and it looked like it could have gotten out, then I would be a lot more concerned. If it's 2 millimeters that's right in the center of the prostate, then I would have a different attitude towards it. And the problem we have right now, and the problem, I'm not a doc, but I would be arguing with Turner, how can you tell this guy to take Zytiga when you don't even know the extent of his disease? And so that segues me into the next step. Prostate cancer, prostate oncology, what are they called? Prostate oncology specialists, is it? Is that right?
Yeah.
Prostate oncology specialists are, as you know, they're an independent group. And the independent genitourinary medical oncologists have always had a very strong, a well-known reputation for very aggressive treatment. So this goes back to Snuffy, who was treating with LHRH plus antiandrogens plus 5-alpha reductase drugs, the triple blockade, 10 years ago and more. And some of them use some really crazy treatments, like what's his name in California with an L? What's his name? Liebenthal, not Liebenthal. I forget his name. Help me, somebody. Who's the oncologist in Los Angeles? Anyway, so the trade-off is that this is his method. These are their methods. And the arguments are that, one, it's overtreatment, two, that it can change the disease, that the cancer can respond earlier in a way that it otherwise may not and become less treatable in the future. And three, that it's to some extent redundant, because you're not just going to be taking Zytiga, you're going to be taking Zytiga and prednisone. And, so you could ask, well, why are you taking Zytiga? Why don't you just add Xtandi, enzalutamide, or Elida, apalutamide? They're all around 10 grand a month. The fourth thing is your insurance company going to pay for it? And if not, is it worth you paying for that drug yourself? Because you probably won't get much I doubt you'll get much from financial assistance based on the stage of your disease. But you might do. So, there's a whole lot of questions. And then the fifth thing, which of course is what you're interested in, is, well, how's it going to affect my quality of life? I think if it were me, and I'm trying to undo what I know about the disease, if I had a doctor saying to me as an early stage prostate cancer patient with 4+5 disease, that I should be taking Zytiga, I think I would be seeking a second opinion and deciding and then if necessary, a third opinion, and then decide from there. Would I do it on the basis of knowing what I know, your situation where you don't know how much disease you had? You could have 2 millimeters, or you could have a chock-a-block full prostate gland. Would I take Zytiga on that basis, along with Lupron and or an LHRH drug and the PBRT, the proton beam? No, I personally wouldn't. I would be getting more opinions. But let me throw it out to some of the other guys and see what their thoughts are on how much treatment you should be doing at this point. Anyone?
I have a question for Roy. You said you did an MRI, and they said the MRI didn't show much. I thought the MRI can pretty much quantify the extent of the tumor in the gland.
Yeah, they used the words they used was there's a lesion or what could be described as a lesion, and there were certain cells that were very suspicious.
Well, did you do the so-called 3 Tesla with contrast?
Yeah, there was contrast. There was contrast.
And was the machine
That's how the report read. I was kind of almost surprised and disappointed with the lack of specificity.
Hi, Roy. It's Rich Jackson. I'm similar to yours. On my biopsy, I've got 5 9s and an 8. They did CT, they did bone scan, they did 3T MRI with contrast. So they've got a much better idea of what I've got, where it's at, and how involved it is. I did blockade, which is Casedex and Luprin, for about 4 months. I did high dose internal, high dose brachytherapy, and 25 external. I was diagnosed last October 17. My high dose was January of 18, and I finished IMRT, guided IMRT, the 2nd of March. Based on what you've told us, I seriously would be looking for some second and third opinions.
So just for everybody's explanation, Roy's a pretty unusual case in that he never had a directed biopsy of the gland. There was a sample that came from doing a TERP, and that sample showed a Gleason 9. And there's no doubt that it was a Gleason 9, but the gland itself has never been properly, there's never been a fusion biopsy, there's never even been an ultrasound biopsy of it. So they're somewhat shooting in the dark. And that's why we say we don't really know. I mean, it could be 2 millimeter nick that they caught, or they could be prostate cancer throughout the gland, but we just don't know. And you know, to me, as Rich says, it kind of influences how you make your treatment decisions, and it certainly influences the hormone therapy decisions. For me, but everybody's different. I mean, it would influence my decision. Anybody else want to say anything to Roy about taking early Zytiga?
Well, as usual, studies are rarely applicable to everybody. But the more recent studies have shown that Zytiga in newly diagnosed advanced metastatic cancer has a much greater survival benefit by introducing Zytiga right away. That's in hormone sensitive, newly diagnosed prostate cancer patients, never had any therapy before. That's not exactly your situation, but maybe that'll help you make up your mind that that using Zytiga upfront very early had significant improvement in overall survival at 5 years.
Any other thoughts for Roy about whether he should go with the Zytiga right now or not?
Well, having done Lupron and Casedex, for a long time. I didn't like, I mean, I suffered through that, but as I said earlier, I'm doing fine right now on Lupron and Zytiga. Of course, my situation is more advanced than Roy's, but I'm not particularly feeling any terrible side effects from it.
Is anybody on the call, or has anybody on the call had bad side effects from Zytiga?
Jake, you're on Zytiga, aren't you?
And Salutamide.
Oh,
No, I'm on Xtandi, Peter.
okay. Oh, I'm sorry.
No?
Hey,
Who
Rick.
else?
Hey, Rick.
Yes.
John Appler. In last call, you mentioned you thought that Arleta was actually a more modern approach than Zytiga because it did not require prednisone. Would you ask Roy about that option as well?
Well, as I said, I mean, I'd be asking Dr. Turner why he prefers Zytiga to Xtandi or Alida, because neither of those two would require the prednisone. And the other thing, of course, is that, you know, we don't know, and we're never really going to know whether the Zytiga is effective. I mean, Roy, the other thing I would definitely do, Roy, is I'd get an ARV7 test, because if you're ARV7 positive, then the Zytiga is going to have no impact, and you're never going to realize you're going.
Yeah, what is an ARV7 test? What is it testing?
It's testing whether you have a variant, whether you have a mutation in your ARV7 androgen receptor. And if you do, then the Zytiga is not going to work. And most men know that, because if they don't get tested, because their PSA continues to rise whilst they're taking the Zytiga. But, you know, the question to Dr. Turner is, if I have that variant and I'm ARV7 positive, how are you ever going to know? I'm going to be taking Zytiga for the next year. You don't know if it's effective or not, because my PSA is so low, and I'm not castrate resistant. But you have no way of knowing whether the Zytiga is working or it isn't working, if you're ARV7 positive. So, you know, you can be spending 120 grand out of pocket, and you may be ARV7 positive. You can get it tested now. It's Genomic Health test has a test for it, and so does Johns Hopkins.
Another way to deal with that, which I did, which is a little bit unconventional, I started Zytiga 2 or 3 weeks before I took a Lupron shot this round. And my blood test showed a significant drop, even though I've got low PSA, but it showed a drop just because of the Zytiga before Lupron even was added. So I knew right away that I was sensitive to it and it was doing its job.
Yeah, but Peter, also you're in a different situation because you know you have metastatic disease. I mean, Roy doesn't even know what he's got. That's the problem.
Right, but I'm just, you know, I was just saying that there's, besides the, I mean, Roy's already started on Lupron, so it's a moot point.
Right. But it is a good
test themselves. It's a way to do it.
Yeah, it's a good suggestion. It is a good suggestion. Take it before you start the Lupron to find out if you respond to it. But you know, Roy, you got to raise these things, because this is what drives me a little nuts about some of these independent guys. You know, they've got all these tools and they love throwing them at the patients, but they don't think it through. And my question to Jeffrey Turner, and he's a good doc, he's Peter's doc, and Peter's had very good success. I've sat in meetings with him. But my question to Jeffrey Turner would be, how do you know if the Zytiga is going to work or not? How do you know I'm even, not so much whether you know it's going to work, but how do you know I'm receptive to it? So you've got to test you for ARV7 and make sure you don't have it. It's pretty prevalent. What I don't know is whether it's something that develops as the prostate cancer develops, or if it's a mutation that can be existing even at a low level, which wouldn't make a lot of difference. I didn't say that very eloquently, but do you understand what I'm saying?
Yeah.
But it's something that's got to be raised with Turner before you get into it. He may say, no, with the level of disease you have, you could never have an ARV7 mutation. And you say, well, can you show me the evidence that shows that ARV7 is only found in men with advanced disease? Is it ever found in men with less advanced disease? I want to see that evidence before I go there and find out, because it might just be an assumption. Len, what's your thought on that?
Well, ARV7 is present de novo in a certain percentage of guys, even if they haven't been treated with any hormone therapy.
Mm-hmm.
Peter's PSA was very low, and yet he still saw a drop in the PSA using when he initiated Zytiga, and maybe it is worthwhile for Roy to take it for a month or two and see if there's any drop in the PSA.
He's already taking Lupron, though, then.
And it's continually going down on Lupron?
Yeah, where's your...
Yeah. My PSA is 0.1. 0.1. 1/10 of 1%.
Oh, yeah. Okay, then I agree with you, Rick. Yeah.
Well, Roy, since you're starting tomorrow a long regimen of proton therapy, I don't know. I would, I'd have another consultation with Turner and ask him some questions, but I probably doubt that he'd want to start something while you're doing the proton therapy. I mean, something in addition to Lupron. I mean, you could even talk to Rossi about this, but it sounds like you're already starting on a pretty, significant treatment. I don't know whether you want to mix it up right now until that's done anyway. But
right.
That's my opinion. But I don't know. I'm not a doctor. I would revisit the thing with Turner since you're going to be in the area. Make an appointment with him either on the phone or drive up to LA and hash it out a little more. Besides, it hasn't cleared the insurance hurdle anyway. So just hash it out.
This is Jake. I kind of agree with Peter. I would, if it was me, I would try to hold off on the Zytiga, keep it as a future weapon, rather than shooting my wad right now. Since the Lupron seems to be working and the proton beam's surely going to help even more, I would hold off on the Zytiga until a later date. You want to keep as many options available to you as you can for as long as you can. That's my idea. That's my opinion.
So
okay. Well, thank everyone for their thoughts. It's a little overwhelming for me, but thanks to everybody.
You're doing fine, Roy. The name of the game, when you have 4+4, 4+5 disease, even at diagnosis and no meds, you don't have curable prostate cancer. You have prostate cancer that you can get a durable remission on, but it can always come back in 10 years, 15 years, 20 years, but it can come back. So these doctors will tell you they can cure you, but they cannot cure prostate cancer that has a 4 in the number, unfortunately. So you're always looking at the idea of a durable remission. In other words, being able to manage that disease for as long as you possibly can. And these guys that you're listening to on this call are all finding strategies to stretch out their treatment for as long as they possibly can. And whilst Turner says, okay, we're going to go in with all our guns firing and we're going to blast this out of the water and we're going to nail it, he may get you a durable remission. With the Zytiga, he may well get you a durable remission without the Zytiga, as I got. And if the disease comes back, you've still got that in your quill. So I think that's the bottom line. Anyway, keep coming back, keep talking to us. We've always got something new to say. I strongly recommend you get another opinion outside of Turner. You speak to a really good GU med onc at UCSF or at Memorial Sloan Kettering or at MD Anderson. Get another opinion.
Okay.
Okay.
All right. Thanks, everybody. Thanks.
Pleasure, and good luck to you with Rossi starting tomorrow.
Okay.
Do you have his email?
It's at 3:20 tomorrow, so everyone think of me.
We
3:20
will.
in the afternoon Pacific time.
Yeah, and update us. Update us how it's going.
Okay.
Rick, do you have
I
Roy's
will.
email for invitations for future meetings?
What's that?
Do you have Roy's email?
Oh yeah, Roy's been on. We've talked to Roy several times, Jake.
Okay.
Ironically, most of you know I'm going away, and I'm going to be spending a week in Israel and then 3 weeks in London. And the week I'm going to be spending in Israel, one of the reasons I'm going is to see my first cousin, who is my favorite cousin, and I'm closest to. And wouldn't you know that he's starting IMRT on the 30th of July. So I'll probably go with him to his appointment. And what impressed me, he's been doing active surveillance for about a year. And so I've sort of been helping him out a little bit. And he's going to start, I don't know what pushed him into treatment. I'll find out when I speak to him. But what impressed me is that he's doing high dose IMRT. So they're going to just do, they're going to do fewer sessions, 20 sessions instead of 40 sessions. Because there's good evidence for these hypofractions. So, I wrote back and I said to him, at least your guy's on top of stuff. I thought that was impressive. Okay. The new Sean, Mr. Bookbinder, what did you do with your ponytail? That's what I want to know. It's gone, hasn't it? Didn't it turn around? Is there anything at the back? Where has it gone?
Well, actually, my hair, I almost was completely bald. This is what's grown back.
Okay. I see.
So it's growing pretty fast. I'll have a ponytail soon.
Okay. All right. We hope so. Tell us how you're doing and what's going on there.
I visited with Agarwal yesterday. So I had the spine surgery, and I'm pretty close to recovering completely on that. I still get pain sometimes. I rarely have to take anything for breakthrough. So, that's good. And I'm now having to do Lovanox. What fun. Give myself a shot 2 times a day.
Mm-hmm.
And I tried to get out of it last Agrawal if I needed to continue, and he said yes. And I said, isn't there something oral I can do or something better than shooting myself twice a day? And he said, it's not as effective and, the usual stuff. So we're doing it a month more, and then we'll see about whether I can switch to something else. The back is almost completely recovered, as I said.
Just hold on a second. I know what Lovanox is, but just tell the guys so that they're probably wondering what the Lovanox is.
Lovanox is a, God, I can't think of the word.
Anticoagulant, isn't it?
There you go, anticoagulant. So the problem is that they found 2 pulmonary embolisms in my lung, PEs as they're called in the vernacular. And so they're worried about getting more PEs. So they're giving me this anticoagulant prophylactically. I don't know, it was like at least 10 different scans and MRIs and all that looked at my lungs and didn't find these PEs. And then right before the surgery, they found them. And so then they put a filter in so that during the surgery, I wouldn't get any clots, but the filter can't be permanent. So then they had to pull it back out. And I had to be on the Lovanox for at least 2 weeks before they would pull it out. So that was fun. They just handed me the boxes of syringes. No one said anything to me about what was going on or how I was supposed to do it. So that there was some paperwork, and so I read the paperwork, and it told me, where to do it, 2 inches on either side of the belly button, and you wash your hands, then you grab the area you're gonna pop, and clean that off with a alcohol cleaner, and then poke it in and push it down. And these syringes have a safety mechanism. So after you put it all in, then you pull it out and push hard on the plunger, and this little plastic thing pops out on top of the needle. So, for that, $10 a day is what my copay is. So that was another reason I was looking at changing to see if I could get out of $400 a month of copay. But we'll do it for another, as things go, I guess that's not too bad. So I'll be continuing that. My health seems to, Dr. Agarwal was really pleased and surprised at how healthy I am. And I'm, continuing from there. The study that I was supposed to be on, that he was grooming me for, failed. It had already failed before I even got on it. The side effects were so great that they called it off.
Wow.
So now they're gonna try something else.
Wow. That was the one. That was the one with the continuous drip, the ES414, right?
That's correct.
Mm.
So now they're trying to figure out a different dosage or way of applying it, but they're not doing anything with it in testing right now. They're just guessing.
We have to tell. I've got to pass that on to Professor Bill, because he was offered that trial a long time ago, but he didn't want to walk around with the belt.
Yeah, well, and that was already the 3rd time.
Yeah. Okay. So what exactly are you doing right now? What treatment?
Hold on a sec.
Yeah.
Talk about lack of courtesy. They all invaded the room I was in and started yakking with each other. All right, so now I should be quiet again.
Okay.
So he's actually going to put me on Keytruda. So I don't know what your impression of that is, but now we're getting back from somebody else. So the Keytruda will start in a little while. He's trying to get Merck to do a compassionate application so that I don't have to pay for it.
Yeah.
Apparently it's fairly expensive. It's an infusion every 3 weeks.
Yeah.
And so it's going to be a week now. He says Merck usually gets back pretty quick and is pretty good about giving them compassionate application. Yeah. So as soon as they come back with that, then I'll start on that one. You know, except for that, I'm not doing anything except the Lupron for the prostate cancer, and I'm very, very frustrated about that because it's been more than 3 months now that I've had nothing.
Where's
so
your PSA?
160 last time.
Okay.
So you know, I was the one that never went over 10, right?
Yeah, that's right.
So now we're pretty anxiety producing to not have any treatments happening.
So, you probably remember Trevor Doherty, who really never had a chance, the poor sod. But we applied for compassionate use of Keytruda for him. This was 2 years ago. And it came through, it did come through pretty quickly. It didn't come through quickly enough for him because he was too sick when we applied for it, but they did give it to him. A couple of questions. Do you know what your MSI is, your microsatellite instability?
I don't think so. I mean, I don't remember seeing that on any test.
Okay, so that's a pretty good, I mean, I would be asking Rahul about that because it's a pretty important indicator as to how successful Keytruda might be. You know, Professor Bill did take Keytruda, and he didn't think it was working. He had 3 infusions. It didn't look like it was working, and then it kicked in, which is a good thing for you to remember. And right before he started with this ATR inhibitor, he saw his PSA drop significantly, so he realized that the Keytruda was doing something. But the way the Keytruda works, if you have a high level of microsatellite instability, it's more likely to be effective. And that can be tested now. So, you know, the question I would have for Agarwal is, what makes you think the Keytruda is going to work, or are we just throwing spaghetti at the wall? Right now, the MSI may have been measured when Foundation Medicine. Who did the last sequence? Was it Foundation Medicine or was it UCSF?
Sequencing? It was the other ones. I had. Oh shoot. Let me see.
Well, the reason
I can't remember. At any rate, I'll figure it out. But
okay, the reason I ask is because Foundation Medicine now does include MSI. I suspect that if it was UCSF, they probably did measure your MSI. So he's going to know it. And my guess is that you have a fairly high level of MSI, which is why he thinks you would be receptive. But I would just drill down on that a little bit with him, Eric, if you can.
Uh-huh.
What was the other thing that went through my mind about Keytruda? I don't know. Oh, I know what else I wanted to mention to you. Professor Bill.
Oh, Gardant.
Oh, Gardant did it. Okay. Well, I don't know if Gardant measures MSI, so you probably want to talk I mean, if they did, then he would have seen it on there, Agarwal. But I would definitely be asking him what makes him think you're receptive, because you don't show any mutations, correct?
Yeah, I do.
What do you show?
PIK, 3CA.
Right. But those are not, I mean, do you show any, yeah, I got it.
Alterations.
I don't think they're actionable, though. I mean, I
Right.
guess what I should have said is you don't show any actionable mutations.
Yeah, I showed HER2.
Right.
Anyway, PDGFRA also, which is T83M. Anyway, those are the ones I show. That was on the Guardian.
Yeah.
Guardian.
You might want to send your report to Bill and ask him what he thinks. I did think, but I think I know the reason. I mean, HER2 is responsive to Herceptin, but I don't think it does anything for prostate cancer. I know that if you've got HER2 with lung cancer, that you can take Herceptin and it can help you control the disease. But if I recall, and I think we've talked about this before, HER2 in men with prostate cancer, the Herceptin is not effective.
That's correct. Yeah, that's what I've heard.
Yeah. But you know, that's what we want to do. That's what we want to know. So you definitely want to know your MSI. And I would just ask Raul, why do you think the Keytruda would work? What I was going to tell you is that Bill correlated his bradycardia, which you had too, with low blood counts. So, and when they gave him a couple of units of blood, it seemed to resolve his bradycardia. And I just wanted to mention that to you, Eric. You haven't had any more electrical issues with your ticker, right?
No, but they still are totally clueless as to my low blood pressure problems.
Yeah.
I have when my pressure drops, I now get involuntary muscle spasms that last about a minute and are completely debilitating. I have to just collapse into a chair or the floor if I can't do anything else.
Yeah.
And I had one this morning where I couldn't get to a chair, and I crouched all the way down to the floor, and then blacked out for a second, and found myself lying on the floor completely. So it's pretty dramatic. I'm no longer driving because of it. So.
Well, Bill had that too. He had that low blood pressure thing too, and they figured out it was related to his CBC. I mean, how are your blood counts? How's your hemoglobin and your red bloods and your white blood cells? Are they all healthy?
They're low on the anemic side. They're below level, but every doctor who looks at it says it's okay.
Yeah, well, maybe you're one of these guys that maybe you need a unit of blood, and that could resolve some of the other issues.
Right.
It's worth discussing with Agarwal, the low blood pressure and the electrical stuff related to your blood counts. Maybe you could be an exception, and maybe you need maybe you function at slightly higher levels, and let's see if that resolves it. Anyway, let's see who else wants to talk to you, and then we'll go to George, and then we'll close up. And who else would like to talk to Eric? Everybody asked me, how's Eric? So now you can ask him yourself.
Eric, as Len, I got to say, you seem healthier, better, stronger than I recall seeing you on these calls in some time, for whatever that's worth. Also, another prognostic indicator for success with Keytruda is the biomarker PD-1 or PDL-1. I don't know if you have that mutation.
No, I don't.
Don't. Okay.
So that certainly is something to ask again, why he decided Keytruda would be effective.
Yeah.
He told me that the expectation was around 20% effective. So, but on the other hand, better to do something than do nothing.
Yeah.
Well,
I'll take 20% if that's all I can get right now.
Yeah, except that again, you don't want it just for the sake of doing it if it's going to have side effects. So just make sure it's the right thing. Otherwise, we're going to come up with something else.
Sure.
Jake, go ahead.
Yeah, I'm one of those that asks about Eric whenever he's not here. So I'm like a mother hen. I worry when you're not here. So I'm always glad to see you. So and then, like Len says, you do look good.
Well, thank you.
Even minus the hair.
Yeah. The giant scar in my back.
Yeah, well.
Okay. And who else? Anyone else want to say anything to Eric?
Good to have you back.
Thank you.
Good to have you back.
Good, good, good. Okay. All right. Well, Eric, keep us posted as always. Let us know what Rahul says. Tell him I said hello, and find out why he thinks you got a 20% chance that it'll work, and let's find out about that MSI. So that's it. Dr. Savier, you have the last 10 minutes.
No, I won't need 10 minutes. I saw Dr. Sweeney about 3 weeks ago, and stopped all my medications and wants to give me 3 months of no tests and then recheck my PSA. So I was a little surprised at that, and but I was happy because I've been doing monthly PSAs for the last 4 years. So, and I've been on a boatload of medications too. So I was actually happy about not having to do that. But my PSA has been going up, but it's still too low to see anything on any scans. So what he wants to do is wait till it goes above 2 and then get the scans to see where the cancer is. If it's there, I don't know. I mean, I had a very good response to all the treatments I've had, so I'm very lucky in that way. I had de novo metastatic disease and widespread mets to my bones and an initial PSA of 94. So I qualified for that number 4 you were talking about, and I had 2 surgeries on my back. So I have a pretty long scar as well. My issue right now is probably the back pain and the neuropathic pain I have in both legs. And not being treated for 3 months is actually a little nerve-wracking to me. But I'm one of these guys that gets real anxious when I get my PSA done. I mean, I I worry if it goes up by 0.1.
Where is it now? What's the I've got a 0.122 back in June.
Well, it's been doubling every 4 weeks. I started with around 0.3, 0.4, and now 0.03. And now it's up to 0.26.
Okay.
So it's gone up, but also my testosterone is back to normal, and my my prostate function is actually coming back. So it's a good thing. I'm finally having erections, which is after 4 years of none. It's pretty good.
Wow, that is good news. How are you feeling in yourself? We have somebody who's just joined us, who is the guru, the poster boy of exercise. I see Mr. Foodie is with us. You see that, Len?
I do. I already sent him a welcoming message in the chat box.
Oh my gosh, Mr. Foodie, what shall we say? The international athlete. And Foodie, we are having great difficulty getting Dr. George to exercise again. He used to be an avid exerciser. His wife is an avid exerciser. And we can't get him off his ass to exercise. And we keep telling him, if you do it, you're going to feel much better.
I'm doing it. About 5 days a week. Yeah.
Oh, tell us what you're doing this week then.
I go to the gym about 5 days a week.
Ooh.
I just started doing some upper body stuff, and I do the sit-down bike and the elliptical machine for about 30 minutes each.
Yeah.
I mean, I pay for it in the evening. My back is not doing well in the evenings, but I just been forcing myself and trying to lose some weight. That I was on the hormone treatment for 2 years, and I gotta say, I'm still having symptoms after 2 years off it.
Yeah.
So it's it really takes a toll on me. I was also anemic too, and my hemoglobin went from 15 to 10, and I was short of breath all the time and dizzy, and nobody seemed concerned about it until I started taking iron, and it actually went back to normal. It went back to like 14, and all my symptoms went away.
Wow.
So I've been on iron. That was Dr. Ferreira that told me to start the iron, and no more shortness of breath. So sometimes, just because they look at the number and they see it's like 10, they don't usually worry about it. But I was having a lot of symptoms, so. But I'm grateful right now because it's been 4 years, and I don't think I would be here without all the treatment I got from various doctors. So, I had, like I said, it was pretty fast acting. It was a Gleason 8, and I basically just started having neuro symptoms in my legs, weakness, numbness, tingling, and I had a spinal cord compression at L3. And lesions everywhere else, my ribs, my hips, my pelvis. I had a big lymph node in my pelvis. So to go from that to a PSA of, less than 0.05 and remain there for a good 2 years after the hormone treatment, it's pretty good, but it's taking me a while to get back to, where I want to be, but.
Well, you also had chemo too, so.
Yeah, I had chemo as well, and I was on Xtandi and metformin, estrogen, and Avodart, you name it. But I know you guys are talking about maybe over treatment for the Gleason 9, but I gotta say I'm glad I did the aggressive approach because I think I'm still responsive to meds if I get back on the hormone treatment.
Well, I wish you would have spoken up. That's why I asked you guys, and that would have been good feedback for Roy. He's gone now. I'm sorry you didn't Because yes, I mean, you were seeing Snuffy, and Snuffy throws the book at everything.
Yeah, but he has a good success rate.
Yeah.
He does.
Eric, there's another great suggestion. Talk to Rahul about, Dr. George's solution with a little iron. See if iron is might work for you too. I don't know, but
I am taking iron now.
Are you? How much?
Yeah.
Well, talk to Dr. George. He can give medical advice. I cannot. How much iron are you taking?
Me, I'm taking 325 twice a day.
Okay, now that's good because I was going to ask you next, Eric. How much iron are you taking? I think we lost you again, Eric.
Yeah, I had it on mute. At any rate, it's not in my list, so I've screwed up there. I have to go and dig out the bottles to find out what the dosage is, but I take one pill a day, whatever it is.
Okay, well, just review that with Dr. Agarwal when you see him next.
Okay.
All right. Well, listen, George, after giving you a ration of you-know-what, I am delighted to hear that you are now exercising. That is great news. If nothing else, we've gotten you back into that gym, and I'm thrilled.
Yeah.
Really.
Well, it's the answer,
Yeah. And I do want to welcome the international athlete. How are you, Mr. Foodie?
Well, I'm feeling really good, Rick, and Len, and all the other guys. I'm still on a high, so to speak, as a result of the international competition that I participated in Florence, Italy. It's an extraordinary experience, and to think that I did that as a stage 4 cancer patient, I just can't believe it. And but I'm very fortunate in that after I started taking hormone deprivation therapy, I found a mentor in Mr. Rick Davis, and he said, "I'm going to tell you one word, Mr. Foodie, on what you need to do." And he said, "Exercise, exercise, exercise." So that led me to find Donna Wilson and her fitness class for men, and that has made all the difference. I'm not sure what would be happening, but I'm stronger today and happier today than I ever was. And it's the exercise and the diet and the nutrition that comes along with that. So, and having a team and training is certainly something. I don't even think about cancer. Everybody on the team has cancer, but we're all in the same boat, so to speak, and we're all working together to, it's a dragon boat race. If you're not familiar with that is, DRAGON, dragon boat race. Do a Google search for that, and you'll see, the sport that I'm participating in, and it's one of the most difficult things I've ever done emotionally and physically, and yet it's something that's really helped me to. It's really helped me in my daily life and in dealing with cancer. I'm not quite sure how that all works out, but it does. It really does. So, but it was really something to be in an international race. It's like the Olympics, So it's like I never ever thought I'd be doing something like that, and I did.
And if you want to see Foodie in his Tommy Hilfiger designed outfit, go to our website, ancan.org, and go to the news and events page, and there's a picture posted of Richard Foodie in all of his splendor. It is medaled. So,
I don't know if you can...
a medal. All right. Really, we're
Bravo,
very...
Richard, bravo.
Bravo. And you had a great time in Florence, I'm sure.
I did. The art is extraordinary, and Michelangelo and Da Vinci. It's just, and it's a small city. You can walk everywhere, and that's what we did in between the training sessions. It was we had free time, but then we had training on the Arno River and workouts in the gym to get us prepared. There were 129 teams from around the world, and the Empire Dragons NYC team, we placed 7th in the world. And what separated the gold medal from 7th place? About 2 seconds.
Wow.
It was really fierce, really fierce. So, you know, it's just, it's amazing. And now I was on the rookie team, and so the rookie team in the whole rookie division, my team came in 6th in the rookie division. So that was pretty good too. So I mean, excellent when you think about it. So,
right.
But that was not good enough to advance into the qualifying rounds to get into the main competition. But you know, I had my race, and
right.
It was
Good
something.
job. So, all right. And one last question before we finish up. What is your next singing adventure?
Well, there's an audition coming up for Bye Bye Birdie, and for the fall. So I'm going to audition for that and see what happens. You know, there's no guarantee, but you know, I'll try it out and see what happens. But otherwise, you know, that's it. I just am learning songs on my own, songs that I really like to sing, and practice that. So that makes me feel so happy, and
Great.
Yeah. So
we love it, Richard. And I will, and, you know, I did hear from Fratello Sierra that if he had realized that he could have gone to Florence, he might have been training with you for that rookie boat as well.
He would have been very welcome.
Well, I don't think I had the willpower that Richard has. He's in a class by his own. That's a lot of hard work he put in, and he deserves to go.
Okay.
I'm a slacker.
An Italian-speaking slacker. All right, guys. All right. Well, look, we'll call it a night. It was lovely to see Richard Foodie on the call at the end, and some good information tonight. I will be doing my best to join the calls over the next 4 weeks, probably more likely to be on this Tuesday call because it'll start at 11 p.m. Than on the other call, but I'm still going to try. I know that Len and Jake will do a really good job, and Peter's going to help when he can. So don't stop coming just because I'm not going to be here 100% of the time, please. And I will be listening to all of the calls. So if I've got any feedback, I'll be writing to you directly. And I'll also be sending out the notices as usual. And that's it. So I'll say goodnight to everybody, and I'll see you when I see you. But I'll definitely be back I'm coming back on the 26th of August, which means the next call that I'll be properly managing will be on. Yes, the 28th, Tuesday the 28th. Tuesday the 28th. Okay, good night, everybody.
Good night.
Good night.
Bye-bye. Ciao.
Ciao.
Hi, Rick. Night, guys.
Good night.
Hi,
Oh,
Jake.
hold on a minute. I wanted to speak to Rich Jackson. Did Rich, are you still there? And Len.
Oh, I was figuring you forgot about me.
I didn't forget. I'm getting you now. And Len, I wanted to get Len for a second, but I'll call Len. Here's my question, Mr. Jackson.
Sure.
With my new fancy computer that I just bought, I don't have any Google files on my local drive. So in the past, what I've done is I've saved my files to my Google account that's on my local drive, and then it synchronizes it. But I guess that the files are duplicated. Now, since I want to keep everything on the cloud anyway, am I better off just using the cloud directly and not keeping anything on my local drive?
Normally they pair up and they'll synchronize back and forth, so that if you're in a hotel, you use the hotel computer.
Mm-hmm.
You can log into your Google account,
Mm-hmm.
see your files, make changes to it, and then it'll actually synchronize back with any computer that's set up for your Google Drive, typically your home computer.
Mm-hmm.
Have you logged into your Google Drive and installed Google Drive on your new computer? With your login?
Right. That's really what I wanted to check with you. I'm not sure how to go about doing that. I did log in on my Google Drive. I did check a file on my Google Drive, but I don't know if I've downloaded whatever I need to download. What would I need to download to synchronize it?
Let's see.
Because you see, what I don't see is I don't see a Google Drive folder in my in Explorer.
Do you have Chrome installed?
Yeah, that's what I'm using, Chrome.
Looks like if you go to so Google Docs. No. You should be able to hit Google and just add do a search in Google for add to drive to your desktop. Let's see what that's got.
Okay.
On your computer, it says go to drive.google.com. Let's see, upload files. Haven't done a great deal with Google Drive, but I do more with OneDrive from Microsoft.
Well, the thing is, we're all set up. We're set up on Google Drive, so I don't want to start with OneDrive right now.
Right.
So when I go to Google Drive, I mean, it's got a lot of it's got stuff on there, but it doesn't have my files on there. It's got just stuff that's I don't even know how it's come through.
If it's what you're talking Google Drive on your computer or your actual Google Drive on the Chrome.
So I just put in drive.google.com.
Okay.
And it's gone to what's called My Drive.
Yeah, that should, once you log in, that should have all of the files from your previous computer. I just sent you a link.
Well, you see, that's the problem. It has a bunch of downloads, but it doesn't seem to have all of my files. It's just showing me pictures right now.
From the cloud version of your Google Drive.
Yeah. I don't know where the files would. I don't know where the files would be.
Is your old computer still alive?
Yeah, I'm actually using the old computer right now, and I've got the new one just opened in front of me.
Okay. So on your old computer, you still see the files that you're looking for?
Yeah. Yeah, they're all there.
Is there a size limitation on the Google Drive? Seems like it's like 5 gig or something.
15, and I'm using
15. Okay.
4.1.
So you still got plenty of space. Because you should be able to synchronize, or it should automatically synchronize from the Google Drive on your desktop up to the Google Drive in the cloud.
But the question is, can I bring the stuff that's on the cloud back down to this new drive?
I sent you a link about downloading Google Drive.
Okay, perfect. I'll look at it.
Yeah, it's going to take you to, a download section in Google.
Okay, I'll look at it.
And you could probably try to run that on your new computer. You can just type it in. But your existing files on your old computer should match what Google's got for you in the cloud.
Yeah, no, it does, but they're all on my old computer. And what I'm wondering is if I want to do work offline, say when I'm on the airplane tomorrow,
right?
Whether I need to copy those and then take them with me copy those files and take them with me on a stick.
Well, again, if it's in the cloud, they should exist basically in both places. They should exist on your computer and on the cloud. They should be synchronized back and forth.
Right, but they do. I mean, they exist on the old computer.
Right.
And they exist on the cloud.
So then once you go to your new computer, download the desktop version of Google Drive and log in as you, then they should start synchronizing back up. You may have to, not sure, you may have to force it to synchronize.
So how do I download the desktop version of Google Drive, I guess?
The link I sent you?
Okay, perfect. I'll look for it.
Yeah, Google Drive, google.com/drive/download.
Ah, okay, thank you. I will look for that right afterwards.
Yeah, and that's going to take you to the Google page for downloading Google Drive.
Okay, we'll do it. That's what I'm going to do next. I keep putting off packing, but I will get to it.
Yeah,
all right.
Definitely as a backup, having it on a thumb drive, having it on a stick with you certainly can't hurt.
Okay. Okay. Thanks a million.
Okay, have a good trip.
Thank you. Talk to you soon. Goodbye.
Goodbye.